So today I'm going to talk about HIV. Is it okay now to talk? HIV and hepatitis C and epidemiology of the two of them, and then how each one affects each other, and then finally a little bit about the treatment of both of them, which is extra complicated and problematic. So first of all, I need to give you a little introduction about HIV. I figure most of you are more hepatitis C oriented, but HIV is a virus which kills lymphocytes, CD4 lymphocytes, the helper T lymphocytes. And I've plotted that here on this side, and this is your CD4 count. You know, your white blood cell count's about 1,000, or I'm sorry, about 4,000 or 5,000, and a quarter of those are lymphocytes, or 20% say are lymphocytes. You have about 2,000 lymphocytes. About half of them are the helper cells, and half of them are the suppressor cells. And the virus specifically infects the helper cell, which is called the CD4 cell. So most people, on the broadest average, have about 1,000 T cells, as they're called, or CD4 cells. And HIV gets into that cell and it kills it. It does it very slowly, and the body tries to recover from it, but the virus continually kills those cells, and the body tries to replenish it, but eventually it runs out. And so over the space of a decade or so, you'll see the CD4 count, which is 1,000, falls and falls and falls. And when it gets under 200 is when the immune system is seriously injured. And that's when people get extra infections, pneumonias, pneumocystis pneumonia, MAC, other kinds of CMV infections. And so that's where the CDC defines AIDS, is when the CD4 count is under 200. So nice round numbers. 1,000 is normal, less than 200 is AIDS. Currently it's recommended to start therapy at when the CD4 count is under 500, it's recommended to start anti-HIV therapy. And then kind of along with it, just the opposite though, is when people are infected, the virus goes way up because the body has never seen the virus before, and then the body tries to fight the virus. And it pushes it down, but it can't eradicate it. It can't kill all the virus. And the virus over time recovers, and it keeps killing the cells. And then by the time people are very sick with HIV, they have very high viral loads. So the good news is that, and this was the course, it was clearly people were diagnosed with HIV in 1986 to 1996. It was the death sentence. They were going to die. There was nothing that really treated it. And then in 1996, we finally figured out that if we had the few drugs that we had developed over that period of time, put them together, things really worked well. And here's the amount of virus here shown on the slide, on this vertical axis, and here's the virus. Say somebody has 1 million viruses. If you gave them one drug, it went down about 10%, and that's all we had until 1990. If you gave them two anti-HIV drugs, you got it down about 99%, which is good, but when you're dealing with 1 million, it still leaves 10,000. And then finally in 1996, we had 3 different kinds of drugs that we could put together in combination. And when you did that, virus would go down to what's called undetectable, where if you do a blood test, you can't find any there. And so that's the undetectable level. And that's what was necessary to actually stop HIV, was the triple drug combination of anti-HIV drugs. And when you do that, most people the virus will go to undetectable levels. And what happens is basically the reverse of what you see here. The virus is stopped. It goes back down, and the CD4 count starts increasing. And so, it may take years and years after treatment is initiated, but many people's immune system recovers significantly, if not completely, significantly. So people do not get, on antiretrovirals, they don't get opportunistic infections anymore. And in fact, people don't, if you diagnose them early enough, you stop this process, they never get to full-fledged AIDS. You've stopped the infection. You haven't cured them, unlike hepatitis C, which we're talking about today. You haven't cured them, you've just stopped the infection. If you withdraw the drugs, no matter when, a decade after treatment, when people appear to be doing fine, if you withdraw the drugs, the virus will come right back and the CD4 count will start falling again. So in contrast to Hep C, HIV is completely suppressible but not curable. So with that background, let's talk a little bit about the epidemiology of these two diseases. And shown on this slide is the epidemiology of HIV on the left and hepatitis C on the right. You notice that to some extent they overlap. Most of HIV, about 2/3 of the world's epidemic actually, is in sub-Saharan Africa here. So about 2/3 of the epidemic is here, with about 10% of it in the Americas and another 10% in Europe, and then the remainder in Asia and China. In contrast, Hep C, you see a large proportion of it is in Africa and the Middle East. On the other hand, it's not quite as confined. Like, I wish I could get the arrow to appear quicker. It's not quite as confined. Most of the HIV is in sub-Saharan Africa, specifically very like South Africa, way South Africa. Whereas in Hep C, it's not so much. It's more broadly spread throughout Africa, and there's more of an epidemic actually in Asia and East Asia as well. So the epidemics overlap some, but not entirely. If you look at the people with HIV throughout the world, that 36 million, and say what percent of them have hepatitis C, it varies greatly. So in some countries where the predominant mode of transmission might be injection drug use, then the percent of people with HIV who have Hep C is high, like in Thailand or in Spain. In the United States, it runs about 30%. So about 30% of the people with HIV in the United States have Hep C. But that does vary. Even in Ohio, it varies. In Columbus, it's lower than it is in Cleveland, and it's lower than it is in Cincinnati. So in Columbus, the percent is probably not much more than 10%. But it does really vary with the locale. I know my colleagues at Hopkins, for instance, 60 or 70% of their HIV patients that they see at Hopkins have Hep C as well, but not the ones that we see. So in the United States, you've talked a good bit about the hepatitis C today. There's maybe 4 or 5 million people who have had Hep C. 3.5 million people are chronic carriers of Hep C. About 30% of them about 30% of the HIV have Hep C. So about 300,000 people. That would be like about 10% of the Hep C epidemic is co-infected with HIV. So about 1/3 of HIV have Hep C, and about 10% of Hep C have HIV. And these numbers are fairly similar across this country and in Europe, where kind of the epidemiology is fairly similar. You've talked today about how people get Hep C. The large majority of them have this through injection drug use. The next most likely is sexual transmission. If we look at the combination of Hep C and HIV and say, of the people with HIV, there are risk groups. Most of the people who acquire HIV, about a little more than half of the people who have acquired HIV have this by male-to-male sexual contact. And you see the incidence of Hep C in that group is pretty low. Heterosexual transmission, this may be a little mixed with injection drug use to some extent. These are people with HIV who have acquired it by a heterosexual contact, you see maybe 10% of those people. In contrast, when I see an HIV-infected person with hemophilia, most of them have Hep C. And if I see an injection drug user with HIV, almost all of them have Hep C. So that's where we get the average of about 30%. So in looking at the HIV population, it really does depend on how they got their HIV, whether they're more or less likely to have co-infection with Hep C as well. Now, how do they acquire this? Well, most of us understand that HIV is transmitted primarily sexually. Hep C is transmitted sexually as well, but it seems to be significantly less so. And when you look at patients with hemophilia who, they didn't start checking hemophilia factor until the mid-'80s. If you look at people with hemophilia, and those are almost all men who have acquired hemophilia, the chance that they would infect their wives with Hep C was fairly low. So sexual transmission, at least heterosexual transmission of Hep C, is uncommon. And in fact, if you kind of look at if a man or a woman has HIV, the chance that they transmit HIV to their partner, or if they have Hep B, the chance that they transmit Hep B to their partner is 5 or 10 times more likely than they transmit Hep C to their sexual partner. So again, Hep C isn't as infectious by sexual contact as HIV or Hep B. Now, saying that, it is fairly clear now in studying particularly men who have sex with men with HIV that they are at higher risk for Hep C. And there's been outbreaks now where this has been looked at, and the sexual transmission of Hep C is fairly well documented now in HIV positive men who have sex with men. And where does this occur? Well, it typically occurs in gay men with HIV who have more sexual partners. It occurs in HIV-infected men who have sexually transmitted diseases. We do know that if a person has HIV and they have a sexually transmitted disease like gonorrhea that you've been hearing about, they're more likely to transmit HIV to their partner, but they're also more likely to transmit Hep C to their partner. So sexually transmitted diseases somehow break down the genital immunity and allow HIV and Hep C to be transmitted to their partner. And then quite clearly, men who practice receptive anal sex are much more likely to acquire both HIV, but also Hep C as well. So Hep C is transmitted more in a gay population with HIV than other groups. So sexual transmission does occur. You've talked a little bit about maternal to fetal transmission, and the same is true here, is that HIV increases the chance that a mother will infect their baby with Hep C, and you'll see the statistics here. If they have Hep C only, there's about a 5% chance they'll infect the baby. There's ranges here. If they have HIV and Hep C, that increases almost threefold or more than threefold, 17%. So, and this mostly relates to the fact that when people have HIV, their immune system is injured, and because their immune system is injured, the Hep C has a chance to multiply more because their immune system is down. And so Hep C is worse typically in HIV-infected individuals, and we'll talk more about that momentarily. But so Hep C, there's higher titers. If there's higher titers of virus, it's more likely they're going to infect the baby. What about the other way around? If there is Hep C HIV co-infection, does the Hep C increase the chance that the mother will infect the baby with HIV? And that's more complicated, and the answer is statistically yes. If the mother has HIV alone, the chance they infect their baby in some of these studies is 16%. If they have Hep C and HIV, the chance they infect their baby is over 25%. So both of them increase the risk of transmission of the other to the baby. That said, this is complicated, and that's the reason I have the May on there, is that most people who have, as you saw in that earlier slide, most of the people who have, not all, but most of the people who have HIV and Hep C are injection drug users. They're more likely to present to the delivery suite without any care at all often. They're less well, their health is not as good, and so they're more likely to infect their baby with HIV to start with. And so whether it's the Hep C that makes it more likely that the baby gets infected, or the fact that they're injection drug users and they're presenting late in pregnancy is not so clear. So it's not clear that Hep C makes HIV more infectious, but the babies are infected more likely anyhow for probably multiple reasons. Okay. And so if we just kind of look at things that, and if we compare Hep C to HIV to Hep B, all of these viruses are bloodborne, and so they're all very likely transmitted by transfusion. They're very likely transmitted by injection drug use. Unsafe needle injections are not as likely to transmit HIV, and I'll explain that momentarily. A needle stick on the job is much less likely to transmit HIV. Hepatitis B, on the other hand, is most likely to be transmitted. We've been talking about sexual contact here, and as I've said, with heterosexual contact, hepatitis B is transmitted very well. HCV is not transmitted so well. HIV is transmitted better. And so if we kind of compare these different infections for sexual transmission, you see that Hep C is the least likely of those to be transmitted sexually. And then perinatally as well, not as likely as you saw from the previous percents. It's 5% versus 15 or 25%. And so HCV isn't as infectious sexually or as HIV or Hep B. So why might some of this be? And it really comes down to a couple factors, one of which is really how much virus is in the bloodstream. If somebody has hepatitis B, they may have 1 billion viruses per milliliter of blood. If they have Hep C, it may be 1 million. If they have HIV, it may be 100,000. And so there's different amounts of virus, and the different amounts of virus in the blood makes the blood or sexual secretions more or less likely to transmit it. And then also the fact that some of the viruses, and this has to do with the stability in a needle, say, or outside the body. Some of the viruses are fairly stable, like hepatitis B, is that it can stay for a long time at room temperature. Even after it's dry, it's still infectious for a long time. Hep C is less so, but still can stay outside the body for a while in a syringe, whereas HIV really, once it's dry, it's considered dead. And so some of these factors play into the role of what's most infectious or less infectious. But for the most part, I tend to think of the more virus in the blood, the more infectious people are. All right, so let's talk a little bit now about what does HIV do to Hep C? Does it make it worse? And so this is a slide that's fairly common. There are cofactors, that speed the progression of Hep C from just infection to disease to cirrhosis to hepatocellular carcinoma. So there are cofactors that accelerate it, and you've gone over many of these. Like most things in life, It's worse when you're older. It progresses faster when you're older. It's faster in people who have alcohol abuse. Turns out Hep C is worse in men than women. Hep C is worse if there's other injury to the liver. So people who have Hep B and Hep C are more likely to have progression to cirrhosis or end-stage liver disease. But lastly on that list is that it appears in a number of epidemiologic studies that I'll review in a minute that HIV does make Hep C worse. And I kind of alluded to that earlier, that HIV injures the immune system. Because the immune system is injured, it can't fight Hep C as well. And because it can't fight Hep C as well, the Hep C gets worse. How worse? Well, worse to start with, you have higher viral titers. In people who have HIV, shown on the right compared to people with Hep C alone, you see higher viral titers. So there's more hepatitis C virus in the blood, there's more hepatitis C virus in the liver on the average if you have HIV. So HIV injures the immune system and there's more Hep C around. That's kind of an obvious thing. If we look at people, and this is a study done in France, and so they look at alcohol use, where they look at alcohol use and the immune system. As I've kind of said, HIV injures the immune system, but there's a spectrum of injury to the immune system related to the T count. So when people have high T counts, high CD4 counts, the immune system is less injured. When they have low CD4 counts, the immune system is more injured. So you would think that if the immune system is doing the fighting, that people who have low T counts would have the worst Hep C, the worst every kind of infection, in fact. And that is true. Here you see when you have people who have HIV and their CD4 count is lower and their alcohol use is higher, they progress to cirrhosis faster, whereas the people whose immune system is better, who use less alcohol, they stay healthier longer. And so this supports the fact that the severity of the immune injury, the severity of the HIV, determines how fast the Hep C will progress. And so here's a dozen studies, or almost a dozen studies, that actually address this. Some done, as you see, some done in Europe, some in Spain, some in France. And they're looking for the relationship between what does HIV do to Hep C in terms of the development of cirrhosis or the development of end-stage liver disease. And for the most part, these are called relative risks. And what that means is that here, combining all these studies, people with HIV in this study are twice as likely to get cirrhosis if they have HIV in addition to the hepatitis C. And in this study, this is again a composition of all these different studies which looked at end-stage liver disease. People who have HIV were 6 times more likely to develop end-stage liver disease if they had HIV and Hep C. And so HIV makes it worse. And so in all these, again, many different groups have looked at this. It's at least 3 times, I've just said 2 times in one study and 6 times in another, but at least on the average, you put them all together, people with HIV are 3 times more likely to get sick, either with cirrhosis or decompensated liver disease, than if they don't have HIV. And as goes on here, this rate is magnified in people who have the low CD4 counts. So the worse the immune system, the faster the Hep C progresses. This is also true with hepatocellular carcinoma. People get hepatocellular carcinoma earlier if they have HIV than people who don't have HIV and hepatitis C. And then the last thing is, if you start people on antiretrovirals, as I said in the beginning of the talk is that when you give people the anti-HIV drugs, the immune system recovers, and sometimes the T counts go almost back to normal. Does that mean that they're fine? And the answer is their infections are much, much less likely, but they're not completely normal. Once people have HIV, their immune systems are never completely normal again. And so even though you give them therapy and their T counts go up, maybe go up even to the normal range, they're not immunologically completely normal. And so can you reverse this problem that HIV causes to the hepatitis C patient by treatment of the HIV? And the answer is not completely. So treatment clearly helps, but it doesn't completely reverse it. Now, does the hepatitis C make the HIV worse? And this is a debatable thing. Does the hepatitis C make HIV worse? And there have been some studies that suggest that if you have somebody who has HIV and hepatitis C and you treat them, and they have hep C, you treat their HIV doesn't do as well. That's not been confirmed by most groups, though, that it does not seem that the hep C makes HIV worse. On the other hand, most of the people with hep C who have HIV have intravenous drug use. And while maybe the hep C doesn't make their life worse, intravenous drug use makes their life worse. And so the intravenous drug use in and of itself may make an HIV person die earlier. And so it is complicated. These are complicated analyses. It doesn't appear that the hepatitis C in and of itself makes HIV worse, but maybe just the lifestyle of injection drug use that may occur makes things worse for the HIV infected person. And then lastly, what the last point on this slide makes, the medicines, and we'll talk a little bit more about this momentarily, the medicines for HIV, for the most part, have to be metabolized in the liver. Even in healthy people, these drugs put a strain on the liver. And so if somebody has a liver that's already compromised by the hep C, you add HIV drugs on it, it could make things worse as well. And so there's a lot of interplay between HIV and hep C and the treatments for HIV. And we'll talk more about that because that's really the key thing going on right now. So we've talked, mostly this has been focusing on the hep C, but I would like to make the point that in terms of liver disease, lots of things bother the liver and HIV. Hep C is one of them. HIV may in and of itself bother the liver, although that's not so clear cut. Hepatitis B certainly is seen is actually fairly widespread in the gay population as well. So hepatitis B can bother the liver. Hepatitis A is increased incidence in men who have sex with men, and so that can bother the liver. So those are just the virus parts. And then when people's immune system is really low, you have other infections. Tuberculosis would be one of them, although not seen here. Syphilis is another. There's these opportunistic infections called cryptosporidium and microsporidium. Those get into the liver. Mycobacterium gets in the liver. So there's a lot of infections that can get into the liver. Substances are common used in this population as well. A lot of our HIV-infected individuals have HIV in part because of their alcohol abuse and poor judgment in terms of sexual partners. And so we see a higher incidence of alcohol abuse in HIV infection. And then lastly, shown on here, are all the drugs that we use for the treatment of HIV, some of which also cause other problems, like some of our HIV drugs can lead to diabetes and liver problems from high lipids. And so it really is, these two problems are really difficult to break apart, and to say the liver disease is from the Hep C in an HIV-treated individual is difficult. And in fact, when we're studying HIV therapies, new experimental HIV therapies, and we treat somebody who has Hep C and their liver enzymes go up, we're never really sure, is it the medication we're giving that's toxic to a hepatitis C infected liver? Is it the immune system that is now healing and seeing a liver that has Hep C in it and starting fight against the Hep C in the liver? Or is it some other metabolic change that the medicine causes that affects the liver? And so separating all these out is almost impossible. And in fact, it complicates the management of Hep C and HIV. But to make the point, the treatment of HIV is really good. People aren't really dying of HIV anymore. You see that here the percent of people who die from infections in 2002 was less than 30%. On the other hand, if you look at what's killing HIV-infected individuals, the most common cause of killing HIV-infected individuals is liver disease. And so while it may not specifically be Hep C, it's still liver disease. And if we look at kind of what are the independent predictors of liver death, being immunocompromised, having Hep C, having Hep B, having injection drug use, those are all things that kind of say you're much more likely to die of liver disease. All right. So how do we take care of somebody with HIV and Hep C? Well, let me tell you that just recently, within the last month and a half or so, there's been guidelines issued by the government. The Public Health Service, every 6 months or so, looks at all the research that's been on on HIV, and they update these guidelines, and they publish these on the web every 6 months or so. And it's called Guidelines for the Use of Antiretroviral Agents in an HIV-Infected Adult and Adolescents. And this is kind of the Bible for the HIV treaters. And you look here, you find out what it recommends, what are the best therapies for HIV treatment. And because hepatitis C is 30% of that population, they also address hepatitis C issues as it relates to HIV. And so what do they say? And so these are from the guidelines. They say everybody with HIV should be screened for hepatitis C. And so that's one of the first tests we do when we have a newly diagnosed individual with HIV, is screen them for Hep C. And if they are at risk for Hep C because they're an injection drug user, or they have multiple sex partners, or are engaged in other high-risk sexual activity, they recommend retesting people every year or so. So if I have an HIV-infected individual, I test them for Hep C. If they're negative and they're participating in high-risk practices, I test them every year to be sure they haven't seroconverted. And then if somebody comes to my clinic and they're Hep C positive, then we have to see if the Hep C antibody positive, then we have to see if the Hep C is active, and we do an RNA assay. And I'm not going to go through these because you're going to hear about these next, about what kind of assays you do to prove whether people have had Hep C or have Hep C. So I won't go through those details. But I would like to make the point right here that there are people, as I said, HIV injures the immune system, and the immune system is what makes antibodies. And so if you have somebody with very severe HIV and their immune system is very low, and then they get hepatitis C, normally we would expect the body to make antibodies to Hep C. But in late-stage HIV, they don't make antibodies to anything. And so they may not seroconvert. And so there are some people who have false negative Hep C tests in late stage HIV. In earlier stage HIV, they probably seroconvert, but in late stage, that would be a CD4 count under a couple hundred. You really couldn't be 100% certain they didn't have Hep C because of that false negative test. Okay, and so the guidelines go on and talk about rather common things that you would expect, that you would recommend for anybody with Hep C, about HIV and Hep C individuals shouldn't be drinking alcohol. That's fairly straightforward. The sexual transmission of Hep C isn't as much as that of HIV, but still we counsel them that, yeah, we know your partner has HIV and you don't think you need to practice safe sex to prevent the transmission of HIV to your partner who may have already HIV, but you could give them Hep C, and so we do counsel them that these are different infections and that just because a partner may have one doesn't mean they have the other, and you can transmit Hep C to that partner as well. So that's rather straightforward. Everybody with HIV who has Hep C, and whether you have HIV or not, people with Hep C should be vaccinated against Hep A and B. And so both Hep A and B are sexually transmitted diseases, and so we know they already have at least one sexually transmitted disease, so you would vaccinate them. And so one of the issues is, when do you vaccinate people with HIV? It's best people who have HIV, if you're going to vaccinate them, it'd be best to wait until their immune system got a little stronger. So typically we recommend treating people with HIV until their virus is down, their T cells are up, and then you vaccinate them to Hep A and B if they're not already immune. So once that has taken place, then it's worthwhile to think about, should you treat the Hep C in this individual? And these are the complicated decisions that we're going to discuss now. There are guidelines about treating Hep C. You certainly, in the recommendations of the government here, not to do it until their T counts are higher. And so one of the issues in determining whether you need the Hep C treatment is a liver biopsy, and this is kind of a routine thing, particularly, again, Hep C treatment is worse. It's less well tolerated in HIV-infected individuals, and it's complicated by medications. So you really want to be sure you need Hep C treatment. And so that is best determined by a liver biopsy. So most people with Hep C and HIV, before the decision is made just to treat their Hep C, is to get a liver biopsy and see if their liver is indeed sick from the Hep C. And so it's still recommended that these individuals get a liver biopsy. All right. So same kind of treatment thoughts as a non-infected person. We'd like to get a SVR, a sustained virologic response with an HIV-infected individual. If you can't get that, at least can you suppress the virus and let the liver heal a little bit. If you treat them and you can't cure them, maybe the liver can heal and maybe they won't get cirrhosis as quickly. So treatment, it's the same treatment as people without HIV. Pegylated interferon, ribavirin. You know the side effects are there, but here's the problem. So if you have a person who has genotype 1, the chance that ribavirin and pegylated interferon would lead to an SVR maybe 40 to 50%. If they have HIV, it's about half that. So the HIV superimposed upon the Hep C, you cure about half the people you would expect to cure. And that is generally, you see this is a large range. There are studies that vary that only 14% of people with HIV and Hep C are curable of their Hep C. Some of the studies, 38% is really a high end. Most of the studies are in the 20s. And so when I discuss this with patients, that they're going to have to take interferon for a year and ribavirin for a year, and that there's a 15% to 25% chance of a cure, a lot of them think twice about it. But again, a liver biopsy which shows cirrhosis, I might prompt them to think about treatment. But it is complicated. One of the biggest problems we see is the ribavirin. You know, ribavirin is dosed per weight. The problem with ribavirin is a nucleoside, and this guanosine nucleoside, this is what a lot of the HIV drugs are, guanosine nucleosides. And so you're giving an HIV drug, and now you're giving another drug that is very similar in structure and in toxicity to what they're already taking. So kind of particularly years ago, everybody got AZT, and this made the AZT-induced anemia worse. And then we used to use a drug, and not so much anymore, Zaret or Stavudine, D4T. It made the toxicity of that worse. And in fact, there's another drug, DDI, which is still in use to some extent, and that, when you combine that with ribavirin, causes such toxicity that you never use them together. And so, particularly until about 2001, these were the mainstays of HIV treatment, that the combination of ribavirin with those was really very toxic. And so it was difficult to recommend treatment when you knew that you were going to face toxicity. I mean, I think back, I had a patient with Hep C who was on AZT. He had bad Hep C. He was treated. He got anemic. He needed erythropoietin. He got put on erythropoietin. The erythropoietin caused malignant hypertension, and he died of a stroke. And it's just this kind of series that these medicines have, sequential side effects and toxicities, and they need to be monitored very carefully. Fortunately, we're not using as much AZT or Zaret anymore, but still, those are drugs that we have to watch, the ribavirin. There's a lot of text on this, and this comes directly from the guidelines that says when to start antiretroviral therapy. I suggested that the CDC and the Public Health Service says to start antiretroviral therapy when the CD4 count's under 500, but that's the patient has to agree to the treatment, and the treatment of HIV is no fun either, and it's expensive and it has side effects, and so not everybody wants to start treatment, but they recommend most co-infected people, particularly those with a high CD4 counts, that is, who may not need treatment of their HIV just yet, because their T count's 700 or 800, maybe they're the ones that we should be treating for the Hep C. They're more likely to respond to the therapy because they have an immune system. And that's where it says CD4 is greater than 500. Maybe you should defer the HIV treatment. And again, this is very complicated stuff, and because it is what medicines are they on for HIV? What are the toxicities of those? How will those interact with their ribavirin and interferon? But they do recommend starting if people's CD4 count is lower. If CD4 count's less than 350, they say treat the HIV, get the HIV under control, and then if you need to treat the Hep C, treat it then. So treat Hep C after you get HIV under control, unless it's in good control already. And then they specify drugs that not to use. And there's a whole laundry list of drugs, some shown here, not to use with the Hep C treatments. Now, you know that that the new agents, the direct-acting agents for Hep C, the tenofovir and the bocephevir, increase the chance that people will be cured of their Hep C from 40-50% to 70 or 80%. And so these work really well. And those have been tested in people with HIV and hepatitis C, and I'm going to talk about that in a minute. But the problem is that those drugs, those new drugs, also interact with the HIV therapy. And in fact, they interact more with almost all the currently used HIV therapies. And so that presents a problem, and I'm going to talk about that now. So these are really good drugs. They work. I'll show you in a minute. And I have to introduce this slide about sustained virologic response. I think you're familiar with the fact that if you treat the Hep C and the Hep C goes down right away, the chance that they're going to be cured is good. So people who have that rapid virologic response, that is that their Hep C is undetectable after 4 weeks, there's an 82% chance in this slide that they're going to be cured of their Hep C. If their viral load is under 50 at 12 weeks, that's an early virologic response. That means that there's a 63% chance they'll be cured. And then, if the virus, the Hep C, doesn't go away that quickly, then there's a less chance they're going to be cured. So these measurements of Hep C virus are critical while we're predicting whether people will be cured of their Hep C. I bring that up because the studies of HIV and Hep C are ongoing. They're not even at 24 weeks off therapy yet. And so here's the studies, and these were presented a month ago in March, or a little more than a month ago in March, of people with HIV and Hep C given tenofovir or bocephevir, and these are the standard ways that these drugs are given. Tenofovir, as you know, is given for 12 weeks up front, and then the interferon and ribavirin are given for 36 weeks afterwards, whereas bocephevir is different. They go 4 weeks on the ribavirin and pegylated interferon, then they get to bocephevir. And so this is where we are with HIV, and the truth is that we haven't followed people in these studies for more than 12 weeks. So we don't know whether they're cured yet. There's no 24-week data. So what happens here? Just as you would expect, those drugs work better. Here are the people who are on, here are the HIV-infected individuals who were given, and Hep C, interferon and ribavirin. Now this is not cured. This is a sustained virologic response. This means that they're undetectable 12 weeks after stopping therapy, 33%, 50%, 45% with the pegylated interferon and ribavirin. When you add the tenofovir, that goes from that average to 70 to 80%. So again, you almost double the percent of people cured by adding tenofovir in HIV infection. Great. Same thing is true here with bocephevir. Here are the people, again, at 12 weeks after the combination. 27% are cured in the pegylated interferon ribavirin. When you add the bocephevir, this goes up to 61%. So again, you almost double the percent of people cured, or not cured, it's only 12 weeks, not 24 weeks. And this other stuff that I have over here has to do with what their HIV drugs are. And let me show you the problem there. When you combine protease inhibitors, which are some of the standards of care for HIV, with bocephevir and tenofovir, those drugs can go down anywhere from 18% to 57%. That means the HIV drugs rev up the liver and chew up the bocephevir and the tenofovir, so that you expect these drugs to be 100%, but they're really 18 to 57%. So the HIV drugs rev up the liver and metabolize or get rid of the tenofovir and bocephevir twice as fast, if you will. That's a simplification. But so HIV drugs affect those agents. What about the other way around? And this is just as bad. because it's even inconsistent. When you give the bocephevir and tenofovir to patients on their HIV drugs, it lowers this HIV drug, one of them lowers this HIV drug by 49%, whereas this HIV drug goes up by 85%. This HIV drug is lowered by 43%. This HIV drug is lowered by 59%. This one's lowered by 42%. So now it's even worse. Not only does the HIV drug lower the Hep C drug, but the Hep C drug lowers the HIV drug. And so you're not getting nearly the drug you expect to be giving. You're like half treating their HIV and half treating their Hep C. And so it really is complicated. It worked, that's great, but this is early on. We don't know whether these individuals' HIV is going to in fact, this week the CDC said, and I'll tell you this, said, don't do this. Don't do this because now we have reports of the HIV failing, the HIV therapies failing in some of these individuals. And just this week there was an FDA announcement that said don't do this because these drug-drug interactions are so complicated. The side effects are kind of what you would expect with these drugs. They may be a little worse in HIV, but again, with the tenofovir rash and with the bocephevir, kind of GI symptoms and anemia, which are kind of what you expect, but maybe a little worse with HIV. Now the good news is there's all these other drugs that hopefully won't do this, but we don't know that. These are our first couple drugs at this, and hopefully we'll have drugs that won't have these interactions. But at the meeting last week, or in March, the AIDS meeting, this was worrisome. And I suspect the Hep C people have been talking about this a while. These are HIV-infected individuals who had Hep C and were cured of their Hep C, and then they got Hep C again. It's not clear here whether it's sexual transmission or not, but the fact that you're cured of Hep C doesn't necessarily mean that you've stopped doing things that keep you from getting it again. And so lastly, this is the summary, and I just told you the FDA said be very careful about combining these things, and this is kind of the recommendations about combining HIV treatment and Hep C treatment. It says very carefully, and it says the science of Hep C drug development is evolving, and it says maybe you should wait. Maybe you should wait because we really don't understand the interactions of these agents. And although everybody's very excited about the Hep C agents and the fact that you could maybe stop the liver deaths that are happening, we're very concerned about drug-drug interaction and that it might not be the best thing to do right now. So with that.